Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hi, welcome back. David Kaufman here and my colleague and friend,
Eileen.
doing another episode on Unraveled. I have a cold, so you'll have to excuse my funny sounding voice and sputtering, et cetera, et cetera. I can hear better.
Just don't spit in my direction.
Don't worry. I consider wearing a mask, but
I don't know if the sound would
have been funny. Anyhow, we are going to talk about all things antibiotics today, antimicrobials. No specific order. I mean, we'll just sort of randomly come up with names of drugs, I think.
I think we've done a lot about antivirals in past episodes, and we haven't focused necessarily on them, but we've had lots of conversations about antivirals, so maybe we focus less on antivirals for this particular episode and talk more about antibacterial, specifically for tick-borne disease, because I've been seeing a lot more of that lately.
If you look, you will find.
Clearly. I mean, I get these stories. I ask your questions now. Any history of tick attachments, of removing a tick, of, have you camped, have you hiked, where'd you grow up? All those kinds of, questions that might lead me to think that there's a possibility for tick-borne disease. And usually there's a yes in one of those questions. So I've been ordering it a lot more and finding it a lot more. But the problem, of course, is, and I always make complaints like, why do doctors order things that they don't know what to do with? Because that happens to me all the time, where patients will bring me, tests that other doctors have ordered, and I'll say like, well, what did they say? What are they doing? And they just say that they don't know what to do. So I'm like, well, why would you order it anyway? And now I've been doing that.
Yeah, but I can understand ordering those tests. I mean, I do think, unlike you, but like some of those other docs that patients reference, I think it's fine to order something if you're not sure what to do with it, but then I think you have some obligation to try to figure it out a little bit.
I completely agree, which is why I'm asking you to talk about
Okay.
Antibacterials. Because usually it's about drugs that I've never even heard of.
Right. So in our population of patients, which we'll define as complex illness, ME/CFS, long COVID, septet, the most common infections that I think we'll discuss the treatment of are the tick-borne infections. And to be very specific, that generally means Babesia, Bartonella, and Borrelia, which is Lyme, but it can also mean Ehrlichia, Anaplasma. I'm forgetting one. Ehrlichia, Anaplasma. I can't remember the other one. But in general, it's the first three.
Okay.
And although I'm already going to go off topic a little, those three infections can be transmitted by ticks, but I want to emphasize they can also be transmitted other ways. So the vectors of transmission, the sources of transmission for Bartonella are everything. I think that's the best way to think about it. It is an incredibly widespread infection. Ticks, fleas, lice, probably mosquitoes, endless reservoir animals, mice, deer, hedgehogs, porcupines. It's incredible, okay? Borrelia theoretically is primarily from ticks, but we're beginning to see evidence of or suggestions that it comes from other sources as well. And both Babesia and Borrelia can be transmitted via blood transfusions, probably sexually transmitted, although less good data. Reasonable case reports on vertical, mother to child, mother to fetus for Borrelia and Bartonella. So it's a big deal, okay? So that's the most common infection group in our patients. And as you said in the beginning, or than I said, the more you look, the more you're going to find it, especially these days with COVID and reactivated disease.
So these bacteria can be reactivated by COVID, by viral infections?
Yes. At this point, as far as I'm concerned, and when I talk to other docs who are doing this, we all agree, we need to think of tick-borne infections, those three biggies, the same way we think about EBV and the herpes family viruses. You get infected, and if you've not been treated, it doesn't go away. It just goes into latency or hibernation or whatever language you like to use, but can reactivate in the face of immune compromise. Because we see it just over and over in the COVID patients. It's scary almost.
And is it true what they say that these bacterium, like never go away, are never fully treated? I've had patients tell me that their Lyme literate doctors, for example, say that they just burrow into tissues and will just sit and hide there
Yeah,
until.
I don't think we fully know the answer to that.
Okay.
I would prefer to think of it a different way, which in terms of Borrelia, that if treated early, you go out hiking in the woods, you come back, you find a tick, you have a nice big target lesion, you've read the textbook, the tick has read the textbook, you take doxycycline plus minus another antibiotic for 3 weeks, 95% of those people are cured.
Right.
They're done. It's the other 5%, which is a growing number, where they didn't get treated or diagnosed, and then they develop chronic illness, and clearly it becomes harder and harder to eradicate that. Can we completely cure it? I think it's possible, but not always for sure, and certainly not always with Bartonella, which is really difficult. Anyhow, so those are the big ones.
Mm-hmm.
You know, we do give antibiotics for other things, but mostly because, in my experience, the patient says, I can't reach my primary, they're not responding, and I have bronchitis, can you give me something? Or I have a UTI, and none of that should be my job, so to speak. I'm not a primary care doc.
Right.
But I'm not going to go into those drugs.
Yeah. No,
Okay.
I want to know about the specific drugs that you would use for these particular tick-borne diseases.
Okay, so, and let's further define that we're talking about chronic illness, not recent acute
Which is the
acquired
doxycycline.
infection.
Right.
Right. So dox is used also for chronic, but there's a big difference.
Oh,
So,
okay.
so when
I use doxycycline to lower the matrix metalloproteinase
right,
9.
right.
So I use it for other, but
It's
but
also
a different dosing.
anti-inflammatory.
It's a neuro. Right, that's exactly right.
Right.
But a different dosing though. So then
Right.
you would use for infection. So go
Right.
ahead.
So when I have a patient where this is happening and we get positive results, I won't go into the testing, but did we already do testing? Can't remember.
I don't remember either.
Okay, so let's say I get positive results. Then actually, let me talk about that for a minute too.
Yeah, I am interested in testing because I've been using IGeneX a lot, although I know that you've told me that you prefer, or prefer is not necessarily the right word, but like T-Lab.
Right.
So some
So
clarity
let
might
me
be helpful.
explain where I'm at now, and I say it that way because it changes. All right, this is it's kind of like the treatment of SIBO. It keeps evolving and
Yeah.
changing based on success and tolerance, et cetera, and new knowledge.
Mhm.
So there's LabCorp and Quest. I don't bother with those tests. If they're positive, fine. If they're negative, I just don't count them. I don't think.
But if they're positive, can you just stop there though? I mean,
Depends on what's positive. I'll get to that in a minute. So
Okay.
if they're positive, it's usually a Western blot, which is an antibody test. So remember our immunologics here. An antibody positive test to a bug simply means you had that bug in you. It doesn't mean that you still have active disease. So if you test me for mycoplasma, which is a bacteria, I'll probably be positive because somewhere in my life I got mycoplasma, between living in New York and residency and not sleeping and et cetera, et cetera.
God.
Okay. It doesn't mean that you have active disease. So Western blot means you have an antibody, but it doesn't mean you have active disease. And there's even false positives with cross reactions. So because the treatment is so difficult, which I'll get to in a second, I've kind of come to the conclusion that I'm not comfortable treating unless I have laboratory tests that are positive for active disease as opposed to direct positive for active disease as opposed to just antibodies. And that's a big problem because in most medical situations in infectious disease, we do actually make the decisions based on antibodies, not just in tick-borne disease, but the mycoplasma. So if somebody has a mycoplasma antibody and they don't feel well, consistent with the clinical picture, I would treat them. But I don't have a direct positive bug under the microscope.
Right.
But it's so crazily complicated in tick-borne disease that I've raised the bar in my head anyhow. So IGeneX, the go-to labs for me have been IGeneX, T-Labs, and Galaxy. They're all three are great labs. IGeneX has been around, I was using it back in New York, so it's been around 25 years at least. I've been sending specimens there. They do antibody testing. They do PCR, which is DNA of the bug in the blood, so that's a direct positive. And they do fluorescent staining called FISH. FISH and PCR are direct positives. Galaxy is primarily a Bartonella lab, although branched out to some direct positives for Borrelia, and they're an incredible lab. And they do antibodies, which I sort of have stopped doing to Bartonella because they're always positive. And they can be negative and still have positive DNA, so it's even more confusing. And their digital drop PCR is remarkably sensitive. T-Lab, which is run by a guy named Bob Mazziani, who was or still is also the chief medical officer of Galaxy. Don't ask me how that works out. Basically said, I'm tired of these antibody tests. I need only direct positives. And so he developed a highly specialized, highly sensitive fluorescent antibody test, FISH test, where he has a molecular probe that's specific only for Babesia, another one only for Borrelia, and another one only for Bartonella. So highly, highly sensitive. And I've used that lab more and more now because if those come back positive, if I trust him and the lab, that's the gold standard. It's direct positives. Okay, so that's pretty much what I depend on. And the reason I'm looking for that direct positive is, we'll launch into now, what I will say to a patient is, all right, we did T-labs and you came back positive for all three. Okay, so here's the things you have to know. First of all, as far as I'm concerned, nobody knows how to treat these infections. We don't know the right answers.
That's important.
All right?
Yeah.
And,
and that makes sense to me, by the way, just from hearing the histories of all these patients about the different antibiotics they'd been on. IV, I mean, I have so many patients coming to me who've been on IV antibiotics for years, and still they say that their tests are still positive.
Yeah, right.
And they're still sick.
And frankly, Lyme literate or not, terminology I hate, Lyme literate, I challenge anyone to tell me this is the right way to do it because we have no clinical trials to show that whatsoever, okay? And there's lots of reasons for that, not the least of which we can't culture these bugs, so we can't really test the way we should.
Right.
So we don't know how to treat. We don't know which antibiotics to use. We don't know how many to use at once together. We don't know how long to give them for. And up until recently, we don't really have a way to follow success or failure.
I think these are important points because we should also, clarify that in hospital settings, if someone were to come in and they were septic, for example, we take blood cultures, we take urine cultures, we can culture for these bugs, and then we can do sensitivity and resistance.
Right.
And so we come up with a list of drugs that we know will kill this bug because we've done it, well, they've done it in the lab.
And beyond that, you can then reculture them and it'll come back negative and bingo.
Exactly. And so I think for people who are listening, I just want to clarify why what you're saying is so important and why it's so difficult to treat, because we cannot do these measures on these kinds of bugs like we do for other bugs that people are often septic about. So
it's huge.
Yeah.
So for example, when Bob Mazziani's lab sends me back positives and he sends these pictures, which are just, they don't make any sense to me mostly, that's great, but it's not growing in a dish, so we can't test any of our drugs against it.
Exactly.
We have no idea what the best drugs are. That's not totally true, and I'll get to that in a minute, but in the conventional way where you put it into a Petri dish and you put a disc of penicillin and a disc of amoxicillin and a disc of doxycycline. We all learn this in medical school.
Right.
And then you look to see if as it grows, there's a halo around the disc to show it's sensitive.
Exactly. And you get that report from the lab, which I used to love when I worked in the hospitals because they would have an S. It would be a list of drugs, and there'd be S, R, S, R, and wherever there was an S, it meant that it killed the bug. And I was like, we're going to use this drug.
Exactly.
And it made it so easy, right? But
so
it's
we
not
just
that
don't
easy.
have those
we
tools.
don't have that.
There's some laboratory tools, which I'll if my voice lasts, I'll explain. But we don't have what we all grew up with. Okay.
Right. You need some water.
I got it here.
Okay.
And then to reiterate something else, in addition to this issue, is how do we monitor success? So in the septic patient, we monitor based on repeated blood cultures and how they look and behave. Does their sepsis get better? Does their hypotension improve? Their renal failure improve, et cetera?
Absolutely.
The analogy I give all the time, which I probably shouldn't because I think I scare patients, but is HIV disease. So, I did a lot of HIV disease. HIV disease is the perfect model to describe this. After 1996, roughly, going forward, we learned that in order to stop this virus from going, you need to use multiple drugs, and at that time it was usually 3. So the patient would come in, they have HIV disease, it was obvious pretty quickly. we would start a antiretroviral cocktail. The viral load, how many viral particles per whatever in their blood, would be 1 million. And I'm not exaggerating. The patient would come back 2 weeks later, if they took their meds. 2 weeks later, I'd repeat the viral load. It's undetectable. Bam, I got the right drugs. The patient's taking them. Game over. Done deal. And if they stay on those drugs, frankly, for the rest of their life without any changes, they might not even need new drugs. The virus can't develop resistance unless it can multiply. We don't have that information in tick-borne disease. So that's hugely challenging. Okay. So with that grim preamble, what do I do and what do we do? So I think most physicians doing this work will agree with what I'm saying, but I'm sure there'll be variations. And I think at some point it'd be great to have multiple treating doctors, I don't want to say Lyme literate, treating doctors come on to discuss it, okay? So what I usually do, let's assume all three are positive. And let me first talk about, actually let me say one other thing. So Borrelia, Bartonella, and Babesia. So Borrelia and Bartonella generally can be treated in roughly the same way. Most of the drugs that work against one work against the other.
Okay.
There are exceptions, and there's issues of combinations. Babesia, actually that's not true. And with Babesia, you need a third drug or another drug, which is quite specific for Babesia. So let me do that first. So Babesia is treated with conventionally with a drug called atovaquone or Mepron. It's this evil yellow fluorescent liquid. It's disgusting.
They have to swallow it?
They have to swallow it.
Oh.
And
even
most of them
notice.
hate it, as I would if I had to take it. And usually you combine that with azithromycin. So if you went to Nantucket and got babesiosis because you got bitten by a tick that had Babesia, you would be treated for 7 days with that and you'd be cured.
Oh.
The problem is the same problem we're discussing with the other bugs. Once you present years and years later, it's not so easy. 7 days doesn't work. It's
Diddly squat.
Yeah, I was going to use another word. All right. So azith and Mepron. Conveniently, one of the drugs of choice for Borrelia and Bartonella is also azithromycin. So if the patient has all three positive, what I will generally do these days, and this is already new, for a while I was doing separately, is initially doxycycline, azithromycin, and atovaquone, Mepron.
Okay.
Which is a lot of drugs. So Mepron can cause diarrhea. It tastes disgusting. You have to take it with a fatty meal.
Can you dilute it to make it more palatable? I mean, can you?
You can try to put it in juice or applesauce.
It doesn't in any way change its efficacy if you
No, that's all right.
Okay.
Doxycycline, has been around for 1,000 years. It's a go-to drug for a million different things, ranging from acne to, metallo, MMP. And it's a great antibiotic, but it is, first of all, it is bacteriostatic, which means it doesn't kill, it just slows down growth, as opposed to bactericidal. And it can cause nausea, it can cause photosensitivity, it can cause, people just don't like how they feel on it, mostly GI stuff.
Yeah.
But overall, it's pretty decently tolerated. It's given orally, usually. And then the second drug, azithromycin, is a different class called macrolides. And the beauty of azithromycin, Zithromax, Z-Pak, that's what people know.
Is that what you use though, a Z-Pak, or is it another prescription?
Well, Z-Pak's just 6 pills, 5
Right.
days. No, this is...
Oh, so this is a longer
I'm going to get to a
Got
duration.
it.
Yeah.
Okay.
So azith is very, very well tolerated, almost without exception. It can cause GI, but usually well tolerated. The beauty of azithromycin is it can be cidal, kill bugs, and it gets a very high intracellular level in our tissues, in our cells, which makes it a very special antibiotic. And it has a long half-life, so that's why you can take it once a day. And you can use very high doses, generally without any problems. So, the thought being there's a dose-response curve. The higher the dose, the greater the chance you'll have good levels in the cells to kill more bugs, et cetera. Okay, so those three would be my starting trio. And I will generally treat for a minimum of a month, but tell patients, get ready for 2 or 3 months on these drugs. All right. Again, no data to support that. All right. Just experience, and
Right.
not just my experience.
And then, just in terms of just like follow up and whether you need to continue on longer, I mean, do you just sort of check in clinically, or do you actually do a repeat labs, the same labs?
So I will do, I'll do labs just to make sure there's no problems, toxicity, safety
Right.
labs.
Right.
Although those drugs actually, I don't even usually bother with safety labs. They're so safe. So it's a clinical decision, but the problem is that these patients don't present with a fever and joint pain and say, oh, I have Lyme disease. They present with, I have orthostatic intolerance
Right.
and SIBO and mast cell activation syndrome. And oh, by the way, I lived in Nantucket and I got 95 different ticks. Oh yeah, we found it in your blood. But they don't have any of the typical symptoms. So
Right.
you can't really follow clinical success very well. The biggest exception to that I find is if they have neurologic dysfunction from the infection.
Mm-hmm.
And there they will say, patients will say, whoa, I got my brain back. Literally, that's the language I hear often. My brain just
It's
came back.
nice.
So there's a clinical feature that we can use to follow. But usually we don't have that. So it is a total, judgment's probably more eloquent words than I should use, but it's a judgment call of how long to treat with this initial combination.
Okay.
So for me, it's usually minimum of 8 weeks, okay, assuming they tolerate it. And then we revisit the whole treatment approach. And the reason we have to revisit goes back to everything I said earlier about these bugs. They're very smart. They have evolved in an amazing way. Mm-hmm. They can hide in these latent forms, cystic forms, round forms, whatever terminology you want to use. They can be very slow growing. Bartonella in particular can just turn off the growth switch, and antibiotics don't work when they don't grow. Okay, they hide out in cells, and azith gets in, but a lot of our drugs don't. Mm-hmm. And so the general approach to these chronic infections is to pulse or alternate the treatments, trying to stay ahead of what the bug is doing. Okay?
Okay.
All right, so now I have to pause and tell about something else. So we have active replicating bugs, and we have latent hibernating.
I mean, I don't mean to interrupt you, but so all these 3 bugs, they're all spirochetes? I mean, so they're all of the same?
No, Borrelia is a spirochete.
Okay, but the other...
Babesia is a parasite.
Oh.
I mean, that's what the class is. And Bartonella is a gram-negative bacteria.
Okay.
Which is part of the reason this gets complicated.
You're also a microbiologist. Wow. I'm really impressed, Dr. Calvin.
Okay.
Go ahead. Sorry.
So we have active and inactive, replicating and latent. So a couple of years ago, maybe 5 years now, at multiple labs, I think the guy's name is Zhang. He did this amazing work where he tested all the drugs we use commonly for these bugs and clearly showed that with one exception, none of the oral drugs worked on the latent bugs, right? And that, I can't emphasize how critical that knowledge discovery is, because what it really says to people like me and to the patient population, and I wish to academic mainstream medicine, is, you know what, we were right all along. These bugs persist. Something is going on. Because mainstream would say, well, you took 3 weeks of antibiotics. I don't care how long you've been infected for. You should be cured. We don't believe it's chronic.
That is still
You're making it up at worst. And and other than that, we'll call it post-treatment Lyme disease, which is just a bullshit term. Okay.
What does that even mean, post-treatment Lyme disease?
I call it a bullshit term.
But when they say it, I wonder what they mean.
And
it is shocking. It's so controversial.
Yeah, and the reason I say it, call it a BS term, is it has nothing to do with post-treatment. The issue is, does treatment work or not? So this was to me, like a huge discovery. All the drugs we use don't work when it goes to the latency.
Yeah.
And that's why it evolved to be able to do that. Not literally the reason, because they didn't have antibiotics a million years ago. But. Okay, so the same group, along with some other new groups, then took all these antibiotics and started playing with them to find out what did work on the non-replicating or stationary phase is another term they use. And it was incredible. They found all these other drugs that we could use or in different combinations that we use now. So the one drug that doesn't fail is rifampin, which I'll go over in a second. And then they discovered these other combinations that can work effectively against the stationary phase. And what I'm trying to say here is if we don't figure out ways to treat the stationary phase, the latent phase, the hibernating phase, we can't cure people. All right? And so that's why we alternate drugs. That was a long-winded explanation of the reason to do it.
No, but it makes sense.
Okay?
I mean, it was a good explanation.
And many docs will alternate with a break. And the concept, which is probably a little too simplistic, is, all right, we're going to blast you with Azith, Doxy, and Mepron. Then we're going to give you 2 to 4 weeks off, hoping we can trick those bugs to grow again, and then we'll go after them again. I don't know if it really works that way.
Yeah.
But there are people that do that.
Okay. Don't you risk during a break, though, that there's just, that they just replicate?
Right, and become even more resistant, too.
Exactly. Anyway, go ahead.
Okay, so generally the second round that I will do will be rifampin and another macrolide called clarithromycin.
Okay.
So that combination is effective, can be effective against Borrelia and Bartonella. It has no role whatsoever, as far as I know, with Babesia. So the hope is that Babesia got killed in the first 2 months. And I think that that's reasonably accurate in general, but I don't think we have enough data to be sure.
Okay. So
Clarithro is a macrolide like azithromycin. It is not as nicely tolerated. It's not a well-loved drug. It causes a disgusting metallic taste in the mouth, can upset your stomach, can cause nausea, all the sort of usual antibiotic stuff. But the big problem is rifampin. So it's a great drug. It's been around 50 years. It's used constantly in tuberculosis. We have a huge amount of experience with rifampin. It has great intracellular levels. It is active against both organisms in the latent as well as the active phase, stationary and active. The problem is it interacts with almost every drug on the planet because it affects some of the SNPs in the liver, the CYP450 SNPs, so that, for example, it upregulates, I forgot which one just now. It upregulates one of them, and that one is involved in the metabolism of our intrinsic, our own hydrocortisone. And so it can often cause adrenal insufficiency-like symptoms because the patient's hydrocortisone is being eaten up too fast, metabolized too fast because of the upregulation of this enzyme. So often you have to give hydrocortisone when you give rifampin, and it sounds counterintuitive. We don't usually want to give steroids.
Steroids, right.
Right. So that's one problem. And it interacts with 1 million antibiotics and 1 million other drugs. And you have to run, I spent so much time running interaction panels because I can't remember them all, and they get so complicated. And so what happens is you and I have these patients. Most of them are on 5 to 10 drugs a day, prescription drugs. I'm not even getting into supplements. And when you run the panel, you'll see, it will increase the level of gabapentin, be careful. It will decrease the level of Lamictal, be careful. It will increase the level of Lipitor, and you might get muscle breakdown. Over all this stuff, and it's like, what do you do?
Right.
And basically all you can do is be careful.
Right. No, absolutely. I mean, there's a couple of seizure medications that have similar problems, but you just sort of manage levels. I mean, you can run levels of drugs in blood. I don't know if with seizure medications you can. I don't know if you can with antibiotics per se.
For most of them you can.
They work, So it's interesting. So rifampin is a problem, but yet very effective.
Right. So it can also raise liver enzymes. So there I do safety labs every month. I've almost never had a problem. It will turn your urine reddish, so you got to tell people that, otherwise they get scared appropriately. Those are the main things.
Okay.
I haven't actually talked about a Herxheimer reaction.
Yeah, that's a question I get often asked.
I was hoping I could avoid that.
First, what is it?
All right.
I've heard so many different things when people describe what a Herxheimer reaction is.
So classically, Herxheimer is named after Dr. Herxheimer. And H.J., what's the J's name? Jarisch, Dr. Jarisch and Dr. Herxheimer.
Okay.
So this is in the last century, early in the century. They were treating patients with syphilis, which is a spirochete. They would give them penicillin, and the patients would get sick as hell after the dose of penicillin. flu-like symptoms, fevers, sweats, joint pains. They were just miserable. And what that is the drug killing the bugs, and the body says, "Oh my God, what are all these dead bugs doing in me?" And it pours out the cavalry, the immune cleanup operation, and that causes inflammation and makes them sick. So that's a HERX.
Okay. And that's been shown, like that's exactly what it is, right? So
Yeah.
Okay, because I feel that sometimes when I talk to other doctors about Herxheimer reactions, and these are usually doctors that are not necessarily within our world, they seem suspicious of this Herxheimer reaction. And
Well, I
so,
don't blame them for being a little suspicious.
Okay.
It is, as far as I'm concerned, a vastly overutilized terminology.
right.
I went out and took a walk in the sun and I had a HERX. Nobody says that, but that's how I feel about it. Everything is a HERX, okay? And it just isn't really that way. It doesn't
Yeah.
work that way. Plus, at least theoretically, you don't keep HERXing. You have your Herxheimer reaction, and theoretically, at least in the Jarisch-Herxheimer original model, then you're better. In our patients, they can keep Herxing, and I believe that.
Okay. And is it related to the mast cell? At
Well,
all?
probably. I'm sure it's related to mast cells.
Okay.
All right. You're going to bring up a whole nother topic there, so hold on to that thought.
I have so many questions.
Okay. So the Herxheimer reaction, I think, is overdone as a concept, but it is an important concept. It's very useful clinically to me and to other physicians because these infections are so confusing that any tool we can find that gives us clinical information is like a gold nugget, okay? So I will explain to patients about the HERX, and if they message me and tell me, I started the antibiotics and for the last 3 days I'm really sick, that tells me I'm doing the right thing.
So is it a timeline kind of thing? So if it's expected right after starting the antibiotics, and then
Generally.
Okay. So if they take the antibiotics and they're fine for 2 weeks and then they start to feel sick, do you still think about
Yes,
it?
I
as a
probably
HERX?
still would.
Okay.
But just to add to the confusion, if they never have a HERX, it doesn't mean I think we're wrong. Not everybody's going to HERX.
Okay. Is there a way that you can
That's why I don't like the
stratify
term.
who is at greater risk of herxing versus another?
I don't know
Just
how
so
to
you
do
can.
that. I don't know.
And then, so you say the herx then resolves in a matter of days?
It usually gets better over time, over days.
Okay. And is there a chance that they re-herx? Is that
Yes.
even a word?
Yes, there is.
There's a relapse
and there's
of the
another
herx?
issue here, which is many physicians treating tick-borne infections because of the HERX, which is an inflammatory reaction, will begin with very low doses of drugs and go up more slowly in order to prevent or reduce the risk of the HERX. I don't fully agree with that. To me, the HERX tells me we're doing the right thing and we need to kill the bugs. And if we go up more slowly from a purely infectious disease concept, going with low doses initially just creates resistant bugs.
Well, right. I mean, it goes back to why they say you have
evolution.
to finish the course of the antibiotic,
Exactly.
right? If it's for 10 days, you got to take it.
Exactly.
You might feel better at day 5, but you have to finish the course because otherwise you risk resistant bugs, which become more virulent and harder to treat.
To go back to my HIV model, profoundly sadly, in the early days of HIV, after we had AZT, which was 1987, we basically killed a lot of people because we used the single drug. They got better, but then within months they got sicker and sicker and sicker because that HIV, the virus, just said, "Oh, screw you," and evolved resistance almost overnight. So,
it's a war
that's tainted, not tainted. It's colored the way I look at these things. So I don't usually taper up like that. The one exception for me is if I'm convinced they have neurologic disease, meaning bugs in their head, in which case, if they have a bad HERX reaction in their brain, that's pretty scary, so I will go more slowly. But I'm not sure that's the right thing either.
So I'm just sort of curious. So do you go based on symptoms of whether there are bugs in the brain, as you say? I know that you don't do LPs, but do you order the LPs?
So it's mostly symptoms.
Okay.
I have done LPs in patients.
You yourself?
I mean, we have a patient together. Not me.
Oh.
I'm not a resident anymore. No.
I could teach you if you
want.
want.
No, thank you.
You can add that to your repertoire.
And she's had multiple LPs that have been positive at Galaxy Labs for Bartonella on multiple times. But I don't routinely do them.
Okay.
And the way I'll make the judgment is pretty much the neurosymptoms,
Mm-hmm.
And so far that's been reasonably accurate. I have a family of veterinarians, it's like 6 people. They all have Bartonella. It's like an occupational disease, occupational hazard, and several have neurologic disease. And in each case, when they got treated or when they are being treated, their neurologic disease recedes. They become functional again. So I don't have the proof. I don't have the bug. So academic medicine may say, well, it may have been just the anti-inflammatory response to the antibiotics, not the antimicrobial. I don't care. They got better.
They got
That's
better.
what matters to me.
Right. That's what we're in the business of,
Yeah.
right? Helping people.
Right. So I said rifampin and clarithromycin.
Right.
So let me shift gears a little bit back to the Zhang group, the group that discovered all this. What they also discovered, because they, the FDA has this, I forgot the terminology, a drug antibiotic arsenal, which can be used to test against bugs. I forget the terminology. There's a term. So they went and they took hundreds of drugs and tested them. And what they discovered was that an ancient, very old drug called methylene blue,
Oh, yeah.
disulfiram, well known as Antabuse, given to alcoholics, and clotrimazole, an antifungal drug, were all effective against the non-replicating stationary phase bugs, Bartonella Borrelia. That was an enormous discovery, if you think about it. So they brought in 3 new weapons. So now I will use those drugs pretty liberally because they work, and it's a way to get at the stationary latent phase. Because it's not that we're just killing one set of bugs. It's like whack-a-mole. We're trying to kill them all in different phases, so it gets pretty complicated.
How do you prescribe the methylene blue? I'm just curious. Do you get it? I mean, obviously it's compounded.
I get it compounded.
Right.
It is available. You can buy it online. I wouldn't do that if I was a patient. You can get it as a liquid, but then your mouth turns blue, and it's kind of horrible. So I get it compounded. It's a little more expensive.
Into capsules?
Capsule.
And what dosing?
You can get it as low as 5 milligrams. I generally will start at 25 and taper up to 100 a day, 50 twice a day. Overall, very well tolerated. You have to be careful because it is a serotonin drug, so you can get a serotonin syndrome. So if your patients are on any of the SSRIs or some of the pain meds or other drugs that will raise serotonin, that can be a problem.
Mm-hmm.
And it's a big black box warning. However,
because of the serotonin?
Yeah.
Mm-hmm.
However, I have not seen it happen in any of our patients, and I readily disclosed that in one patient I didn't even realize she was on Cymbalta or something, which is an SSRI, and she was fine.
Yeah.
But I'm still very cautious, and I give them all the information. But I haven't seen it happen.
Okay. Well, that's important to know. I mean, I've seen a handful of serotonin syndromes.
And the beauty of
but not very commonly.
Right.
Yeah.
I haven't seen any in these patients. So methylene blue is a pretty cool drug. It's in your field as well, as you probably know.
Mm-hmm.
So it's used for stroke.
Yep.
And it improves circulation and oxygenation.
I really like methylene blue.
It's a great drug.
I use it, I wouldn't say often, but not infrequently.
Yeah.
But I've never used it for infectious control.
So disulfiram is Antabuse. It's a drug given to alcoholics in this sort of medieval therapeutic rationale, where if they drink alcohol, they'll get sick as hell.
Right.
So it does work. It's actually pretty surprising. There's a great Lyme doc named Ken Liegner who published a case series showing how well it can work with a bunch of patients. That drug I'll start on a very low dose and taper up. So I'll usually start anywhere. It comes as a 250 milligram pill. So I'll start as low as 32 milligrams and taper up. Generally well tolerated. It can cause peripheral neuropathy, but usually doesn't. You don't really see that till you get up to the 250 range.
Okay.
Alcoholics are given 500 a day, so they're really at a high dose, and
wow.
They seem to do okay. So peripheral neuropathy, it can cause some neuropsych symptoms, depression, and mood changes. Usually not until you hit 250, but that's important to explain to patients. And I use them together. So the disulfiram and methylene blue together. I'm less sure about the clotrimazole. It has to be compounded into extended release. Less sure meaning I'm just not sure it's really killing bugs.
Mm-hmm.
The beauty is, though, it has no side effects. So, I do use it, but not as much. And so these different combinations will just kind of alternate and go back and
Right.
forth.
So I was going to say, so do you use do you do a combination of these three drugs that?
Well, I'll often add methylene blue to any one of these combos.
Okay.
Yeah.
Wow.
And that's a question. The question, and I don't know the answer to this, a question is, should we design regimens that are active against replicating and stationary phase at the same time, or should we have replicating protocol and then
Right.
stationary protocol? And I don't know what the right answer is because we don't have any studies.
Right. We need studies.
Yeah.
So what about all the IV drugs that a lot
Right.
of these patients are on or have been on?
Sure. So before I get to that, let me just add one thing. So the drugs I just described are the sort of standard drugs. Okay.
So all
But
doctors who treat tick-borne disease would use.
they're going to use these drugs a lot.
Combination of
But
these.
but we also use Bactrim, which is a sulfa drug,
Mhm.
sulfamethoxazole. We used to use. I have only one patient, I think, in the last 10 years. Cipro, the fluoroquinolones. They are now,
People don't want. I
Right,
mean, I have
forbidden.
a lot of fluoroquinolone toxicity patients.
Yeah, I agree. So I don't use that. High dose penicillin, amoxicillin, augmentin. They're all active against these organisms, so we
Mhm.
can use those. And amoxicillin and penicillin can be very effective, but they have short half-lives, so you have to give a ton of
Right.
it. What am I missing?
So if you were to use the appropriate dosings, though, are they as effective as these other drugs that you've already described and drugs that you're going to be describing, like the IV? I mean, I guess why I'm asking this is because I find myself when I feel forced to treat something that I have found of an infectious nature, I tend to go with those drugs because I'm so comfortable with those kinds of
Right.
drugs, the amoxicillins and the penicillins and things of that nature. And I often wonder, am I doing a disservice because I'm not using these other drugs that I've never used before,
Right.
that I'm just not comfortable with? And I want to be sure that I'm choosing appropriately for the patient's benefit.
No,
And so I often wonder, maybe if I understood these other drug regimens better, that I would choose them. But is there any downside to
No, I
doing
think
the
that they
more
can be very
commonly?
effective. They
Okay.
can be very effective, but you
Okay.
have to get a high enough serum level, plasma
Right.
level. So,
Right.
and there's a Lyme doc in the East Coast, Joe Barascano, who's been doing this since it started, basically.
Yeah.
And he used a lot of the penicillin family drugs, but would follow their levels.
Okay. Oh, that's
those are drugs we
smart.
can get blood levels on.
Yeah. No, that's smart.
And you want to get a really high level, and that's not so easy to do.
Right.
So I left off one Babesia
Mm-hmm.
oral drug, which is called tafenoquine. The brand name is Aracoda, I think. And that's an anti-malarial drug, and that can be very effective. So often I'll kind of switch back and forth if I think we still have Babesia showing up. And I'm sure I've left off some of the other oral antibiotics for all these bugs.
So are anti-malarial drugs in general also effective for
Well, Babesia is a malaria-like parasite.
Yeah, that's right. It makes sense. Yeah.
It affects red blood cells.
Mm-hmm.
So yeah, they are effective.
Okay.
At the risk of having us shut down by the FDA, ivermectin can be effective for all these organisms, particularly Bartonella. And I have some of my chronic Bartonella patients who will absolutely tell me, without a doubt, every time they stop ivermectin, they get worse, and every time they restart it, they get better. Maybe it's not killing Bartonella. Maybe they have some bug we don't know about. I don't know the answer.
Right.
But ivermectin is up there too.
And so you don't even consider these co-infections like they used to be called, or still are sometimes. Like these are all individual infections. We used to say like Lyme and its co-infections kind of thing, but that's no longer.
Well, people still
appropriate.
talk that way.
Okay.
One of the things that I kind of went on a minor crusade about a couple of years ago was the emphasis on Lyme disease in the Lyme community, right? The the non-academic mainstream medicine Lyme community,
Yeah.
because I felt like they were really missing the game. They didn't understand, because it's not just Lyme; it's Bartonella and Babesia. The other co-infections, Ehrlichia anaplasma, are relevant, but they're pretty easy to get rid of with
Yeah.
the same drug. So I'm not spending time on that. But I think it's a terrible mistake to only think of this as Lyme disease. And I will
Right.
try to correct patients and people all the time. I gave a talk at ILADS, which is the International Lyme Organization. It's like an alternative to mainstream infectious disease, okay? And they're a great group that have been doing Lyme disease and tick-borne infections for probably 15 years or more. And my talk was titled, "It Ain't Just Lyme," because I wanted to push this idea that by only thinking that way, you're missing Bartonella, which is
Yeah.
really so key here in these patients.
Well, especially since they have different treatment options,
Right.
right? So I think that's important. And also, if you just think about the reservoir, like why would it just be Borrelia? Like
And
it,
also they cause different, clinical pictures.
yeah, absolutely.
Babesia can cause shortness of breath. Bartonella can cause terrible neuropsych symptoms and blood disorders. And Lyme can cause, joint pains and flu-like symptoms. I mean, they're all there. There's
And what about
overlap
those
like a Venn diagram.
Which one is the striae?
That's Bartonella.
That's Bartonella.
Bartonella, yeah. So I want to just pause for a second and emphasize how difficult it is to treat these infections if that hasn't come across.
Well, it certainly has come across,
Okay,
but
good.
even like now, again, all those IV antibiotics. Like,
Right.
so that was my first sign that clearly this is difficult to treat, that now these patients are all on these IV antibiotics.
So I don't do IVs as much as I used to.
Okay.
Partly because you need a PICC line or a port, so that raises the ante. Now you have a risk for infection and blood clots and pulmonary emboli 24/7.
Mhm.
So one needs to be pretty convinced of the need for IV antibiotics to make that big step. That said, the beauty of intravenous antibiotics is, number one, you avoid the GI toxicity of doxy and chlorithro and all these drugs. You can potentially get very high levels. You can potentially get better crossing the blood-brain barrier into the brain. So they're important, but the oral drugs do work, and you can get good levels. So, for example, so when would I use it? So if I have a patient with pretty clear-cut neurologic Lyme disease, okay, they present. This is more of an acute presentation, which I don't see as much as I used to. When they present with a facial paralysis, I just blanked
Bell's
it.
palsy?
Thank you, Bell's palsy. I will not hesitate to put them on intravenous ceftriaxone very quickly. And I've used a lot of intravenous ceftriaxone for Bartonella, but I'm not convinced it's that effective. There's other drugs. You can use IV gentamicin is incredibly effective against stationary phase Bartonella, but it's also really toxic. Can cause kidney disease and loss of hearing and loss of balance. So you better be really careful if you're going to use it. Intravenous penicillin in high doses is pretty easy to use and can be very effective. IV azithromycin in high doses is great. But the question is, how much better are the IVs than the orals? And
Right.
Maybe it's just as I get older, but I'm less and less convinced that we need to do the IVs all the time.
Okay.
So what else? So there's a new drug, which is an old drug, approved around the world, but not
Repurposed?
in this country,
Okay.
called azlocillin, which this group I keep alluding to has tested, and Stanford has tested, and I think Ed Breitschwart's group down at North Carolina State are testing. It looks really effective against these bugs, but it's not available, and it's infuriating. And it's actually approved. It's another one of these things like Ketaz, right? It's FDA approved, but it's not available in this country.
Yeah, it's amazing.
It's like such a racket. I don't understand that, but I won't get into the politics. So here's a drug which every test in these labs, which I was describing, shows its effectiveness, especially when paired with one of the conventional antibiotics, but we can't get our hands on it.
And we're going to end up sort of railing against the. But I agree with you. I mean, obviously there are ways of getting these drugs from other countries, but that is a lot of bureaucracy, a lot of paperwork, a lot of hassle, but also,
Well, it was in today's Times. I think it was today's Times. Yeah, it was in today's Times. Today's Times. Uh, Hallelujah. Bang the drums, blow the bugles. A new drug for urinary tract infections. The first new drug in 30 years for urinary tract infections. Oh, and by the way, it's been available in Europe for 40 years.
Yeah, I know.
40 years, okay? And they don't say this in the article. I actually read the article hoping I'd see this. All right, politics. So why is it available? Because a hedge fund bought the pharmaceutical company and the rights and invested in getting the FDA to approve it. It's not available yet, but I guarantee you it will be so expensive. And it's been around for 40 years.
Well, I was going to say, actually, that is the problem. And, in fact, on the television these days, you always see these new advertisements for these advertisements for these new drugs. And you think, oh, that drug sounds great. And then you try to order for a patient. And one, like, you need to get prior authorizations for everything. And then it's like, it's always denied because it's ridiculously expensive.
Right.
I mean, I just tried a new JAK kinase inhibitor and which I think would be really helpful for a particular patient, and it's like $70,000 a month, like something insane like that. I'm exaggerating, of course, but maybe I'm not. Actually, it was incredibly, insanely expensive. So so even when it is FDA approved, and we as doctors are allowed to prescribe it, it's impossible to get. So for some reason, every episode we can't help but
well, I think it's part of our frustration because
it is part of our frustration.
By definition, everything we do is off-label.
Yeah,
that's the problem.
Yeah, well, and I stopped saying the word off-label. I just repurposed the drugs.
Okay.
Repurpose, repackage. Reuse.
Well, I say off-label only because that's the excuse that the insurance companies can use to deny care and say go screw
yourself. Or
it's
experimental. I had one insurance company say that I was using it for experimental purposes, and I gave an entire explanation about why this wasn't experimental, but they don't care. Anyway, so I agree. There are a lot of drugs that are effective and not and approved, but not available. So
I did leave off one IV antibiotic that's important to mention. That's daptomycin with a D. Daptomycin. So that is very effective against stationary phase as well. Latent organisms. So I've used a fair amount of ceftriaxone and daptomycin together. Pretty well tolerated. The problem here, as you said in the beginning, is how do we know when we're done, and do we cure people? So I don't know if we're nearing the end here, but let me go down that road for a minute, okay?
Yeah, because I do have a question along those lines, but go ahead.
So as I said in the very beginning, the ideal thing would be able to, aside from knowing all the right drugs, how do you know when you're done? Can you do an HIV viral load?
Right.
So I have never been able to use the IGeneX testing for that purpose, because the disappearance of an antibody, a Western blot, doesn't necessarily mean you cured the patient. So I've never done these serial IGeneX, which I've seen many colleagues do. I've had extensive conversations with Bob Mazziani at T Labs, and he argues that you can use the fish testing to judge success of treatment, and he does that with his patients, and I've started to do that. And I think he's probably right. The problem is that, his tests, if you do all three, is $2,000. So doing serial testing for $2,000 is like a big deal. And at the moment, he's the first to admit it's very qualitative, not quantitative. So I don't know if you have you seen a T-Lab report?
I have, yeah.
So you get back two little thumbnail images with nice red blood cells. That's the easy part. And then if you have a good, careful eye, you'll see a few little faintly green fluorescent specks, like maybe 2.
Right.
And that's called positive. And I've had the conversations with him, and he explains that, well, that's not all he's making the diagnosis based on. He does 20 or 30 of those, and he just happens to select those 2 images, which I think is an error. He should get worse images, with more specks.
Yeah.
But I have seen some where it's just covered in positives. And when I say qualitative, it's basically seeing if there's less and less and less. But it should be quantitative, where we can really decide.
Yeah.
Okay, that's part A. Part B of the conversation with Bob and some others, and gets back to, again, what you asked in the beginning. I actually do think that that there's a cohort of patients and people where we're never going to completely cure them. And if you think about it, that should be okay. they were infected for 30 years before they met me, and they were okay, all right? Or, you know, before they had COVID, they were infected, then they got COVID and long COVID. That's an easier example, okay? So what that tells me is, just like I have EBV and HSV1 and HSV6 and CMV in my body, I am not sick from those infections. They are not causing symptoms. Theoretically, and hopefully
Well,
in reality,
you're sick right now, so.
I know I was leading myself into a pitfall, but that I have a relatively competent immune system, except when I visit grandchildren, a relatively competent immune system preventing reactivation. And the same, theoretically, is true for the COVID patients who had infections 20 years earlier, and it's quiescent, it's not active.
Right.
So it may well be that what we need to be focusing on, as well as treatment, is how do we boost the immune competence and maintain it, and kind of wrap our heads around the idea that the goal isn't cure, it's coexistence.
Right, right. So, and that brings me to the question that I actually had, which is that at some point, as you've already said very eloquently, that we're not usually not curing the infection itself. And at some point, but if there are still symptoms despite all the antibiotics and all of the best of the treatment regimens, I've always seen this sort of as an immune dysregulation problem. And
I
so then
agree.
that's where I as you know, I use a lot of immunotherapies, and I've started to really even up my game on immunotherapies with chronic Lyme patients, for example. And, and all of my, let's say, autoimmune encephalopathy patients have some history of infection, usually including tick-borne disease, not only viral infections, but tick-borne as well. So I've been just approaching it as this is like I never say post-treatment Lyme disease, but I do think of this as sort of like, after the Lyme disease and after all the treatment, now you've got this immune problem that's creating all these symptoms because the immune system is just like in chaos.
Right.
It's sort of how I describe it to patients, and I treat it as such, and I try to just
that's exactly what I'm saying.
Right. So it's is it accurate to say it's an autoimmune problem, despite the fact that I often don't find an antibody, though sometimes I do, but often don't. But I still I feel it as such, and I see it as such, and I guess importantly, they respond to the immunotherapies, right? So,
but let's be specific for a second. When you
Okay.
say immunotherapies,
yeah,
or when I say immunotherapies, I'll do it that way. And my goal is to raise the competency and functionality of the person's immune system,
right,
not by using drugs which are potent anti-inflammatories necessarily. So for me, those drugs, to do what I'm saying, would be things like plasmapheresis and exosomes
Yes.
and peptides
that's exactly what I do
and
first.
rapamycin, because it makes me really nervous, again, partly because of my life in
Right, 'cause you-
HIV, to give drugs which are immunosuppressive,
Present.
which we think of as modulating, but they're immunosuppressive.
Right, but it's also a level so if the immune activity is this high, it's okay to bring it down a little bit, right? So to what you hope is normal,
right.
because sometimes that hyperactivated immune system is what's causing the problems. And I think that a lot of times we're treating what we think is infection when it's really just a
Right.
hyperactive
Well, that
immune
makes
response.
sense. That makes
And
sense.
actually, if you think about mast cell activation syndrome, and it's, that's part of the innate system, that's sort of what it is, right? It's a hyperactive mast cell kind
Right.
of. So that's how I've looked at it. But again, obviously when a patient is first diagnosed with an infection, that's certainly not where I go first. In fact, what I do first is send them to you, because I don't know what else to do, as I
Yeah.
started this episode by saying. But I get a lot. Patients don't come to me with, I'm not diagnosing infection left and
right.
right. I get these patients who have been diagnosed with infections, with chronic infections, that have had all those antibiotic treatments and are still sick. And they may not be as sick or the same kind of symptoms as they had been when they were first initially presenting, and then were diagnosed with Borrelia or Bartonella or Lyme or Borrelia. That Borrelia is Lyme.
Right.
Bartonella, babesiosis, that's the one I was trying. The bees.
Yeah, the bees.
But they're sick in a different way now. And so I just sort of see it as, and then they respond to immune therapies. And I completely agree with you. I first start with things that are
Right.
more immunosupportive, if anything, and more broad spectrum, right? So things like plasmapheresis, which I really love, IVIG, exosomes, peptides. I have found great use of those treatments. The problem, of course, is that they're expensive, and trying to get insurance coverage for
Oh, of course.
IVIG is
Yeah.
like,
They're
unless you
expensive
have
and
an antibody, it's basically
right.
impossible. So which is why sometimes some of the drugs, especially ones that have been around for a really long time, like rapamicin's a good example, but there are others, as you know, those are cheap and often covered by insurance and goes through the pharmacy, and often
The-
oral, though not all of them. But so it's sort of this, I think every patient is different, and I
Yeah.
make a decision based on each patient, but that is in a generalized perspective of how I see these patients and how I approach them even after all their
Right.
antibiotic treatments.
I mean, I agree with you completely. The challenge, and it's a scary challenge, is when you use that example of the immune system. Is it up here because of ongoing infection, and if you lower it, the infection will get worse?
Right.
Or is this left over from the infection,
Right.
and lowering it down will be hugely beneficial? And my concern is I don't know how to distinguish that very well.
Yeah, I don't know either, except that we have no evidence to support anything that what we're saying, certainly not what I'm saying, but I think I've made it my business to learn a lot about the immune system and its interactions, of course, with the nervous system. But I do see, and that's why I refer to it as immune dysregulation. When the immune system is provoked for such a long period of time, it doesn't really know how to sort of end its game. And so I see that example as this piece from here to here. I wish we had a whiteboard.
Yeah, I know.
And I would shade in that area. I feel like that is hyperactivation that is not doing anybody any good.
Right.
And if anything, it's actually causing more problems.
No, I
And
agree.
in fact, if anything, I believe it just makes them more susceptible to other exposures because the
I
immune
agree
system
with
is
you.
not doing its job well. And my goal, of course, is to prove everything that I say that it's true.
Yeah, no, I think you're right.
But
recognize we
yeah.
need to also acknowledge or recognize that the flip side is also happening. So I have many patients who have
Yeah.
immune deficiency
Right.
based on their IgG levels and their subclass levels and their B cell counts, their CD19 counts. And I'm convinced that's because they've been infected for 25 years.
I agree.
And even published a paper, a small case series
Yeah.
of Bartonella and Borrelia, where their IgG levels, they became immune deficient.
No, I completely agree with you. And I will say, though, that the counts of the cells of the immune system are usually low. They're not high, but it's the activity that's elevated.
Right, it's what you see going on.
Exactly. And you can actually, even sometimes some of the complement tests that I do, those are elevated. Some of the other modulators, like the TG, like the chemokines and the cytokines and the interleukins, those are elevated. So the cell counts of the immune system, I agree with you, are absolutely sometimes normal, but usually low. So that's right. So that would, you would think immunodeficiency. But first of all, as you know, the immune system is so complex that nobody completely understands it. I mean, PhDs in immunology obviously have a greater understanding of it than I do, for sure.
Certainly, yeah.
But just from all the patients and all of the reading and all of the work that we've done, like this is what I believe to be true. I say that a lot, by the way. This is just what I believe to be
But
true.
I think
I'm
we
willing
have
to
to
be
we
wrong.
have to talk that way
I'm
because
willing to be wrong. Yeah.
This population of patients are
Right.
so challenging and
Right.
complex. There's a reason we call them
Exactly.
complex.
Yeah.
Is that we can only do it based on what we know from the past,
Right.
and what we learn from experience, and what we then think and hypothesize. There's no other way to do this.
Absolutely.
So yeah, I think what you're saying about the immune system is absolutely spot on, including that it may be this high, and that's making it less competent. If we could quiet it down and smooth it out and say, be good, calm down, it would be more effective treating the bugs, you
Right.
know?
Exactly. I mean, and again, that is what we see with the immune therapies that we do.
Yeah.
We see improvements, and so there's got to be something behind that. And so that's sort of how I've interpreted it in my brain. So I think that sort of covers, those tick-borne.
Yeah, so I left off one thing, though, that I should have
Okay.
started out saying. I will generally not initiate treatment after getting labs back that show me direct positives
Okay.
until I feel reasonably confident that I've managed the patient's mast cell activation syndrome
Yes.
and their orthostatic intolerance.
Right.
And it's very frustrating for some patients because they understandably say, well, wait a minute, what about these bugs there? That's what's causing the problem, right? And my answer is, well, I'm not really sure that's what's causing the problem, but I am sure that if I give you these drugs, you're going to get sick as hell because
Yeah.
of your MCAS and your orthostatic intolerance, and then you develop a herx and you get dehydrated, and then you're going to start fainting.
Mhm.
So I want to control those first. And that's
Yeah, I think that's
frustrating for patients,
important.
but it's very important.
It is important because, I mean, especially the orthostatic intolerance, which is very much related to the mast cell activity, but also has its own reasons. And I think that because the autonomic nervous system plays such a huge role whenever there's an immune system dysregulation
Right.
or an infectious process, especially a chronic and systemic one. I think that it is so important to sort of get the autonomic system under control, as well as, of course, the mast cells under control, because they're first responders, as we say, and so they're not going to recognize that this drug is a good drug because it's got to treat that infection.
Right.
They're going to say, "What's this
Right. If
horrible
they're already
toxic drug?"
hyperreactive.
Right?
Yeah.
Exactly. So, I agree with you, and that's a lot of the work that we do. Especially when patients are going for surgeries, which is
Right.
another episode we're going to do. But that is an important piece of treatment to get under control before you start in on really trying to manage the infection with these antibiotics, for sure.
But it's a double-edged sword
a double-edged
problem
sword.
because it's well shown. There's some beautiful papers that show that Borrelia can cause mast cell activation
Yeah.
syndrome. So, doctor, why won't you treat my Borrelia? That's why I have MCAS. And the answer is, well, because I think the MCAS will get you before the Borrelia if I don't
Right.
treat it.
That's right. No,
You know?
it is. Yeah, I mean, I think you sort of have to weigh it, with each patient,
Right.
and I'm sure you do. Do patients ever convince you to do something different than what you otherwise would have done? Like, do they ever give you a convincing enough argument to start with treating the infection first?
No. And there's a reason, okay? That's a great, great question, probably a whole episode question. I do think that I would like to think that I work in alliance with my patients and that we come to decisions on treatment often together. Do you think we should start this or this? It's not just my decision. But having said that, I will not make that decision. I will not let a patient push me to give antibiotics before I think it's appropriate, because at the end of the day, I am totally responsible for writing all these drug orders without the proof that I'd like to have that I'm doing it correctly,
Right.
meaning that there's evidence, not that I'm wrong, but that I'm doing the right thing. So to me, it's a huge responsibility, and I take it very seriously. It's why I get crazy when patients don't do their safety labs. All right, they think that I'm a pain in the ass. They think that my staff is a total pain in the neck. We're not renewing your antibiotics until you do your safety labs, but there's a reason.
Yeah.
I'm responsible,
Yeah.
and so often I will negotiate,
Yeah.
but I don't usually negotiate
No,
on
and
antibiotics.
I think you bring up an important point. I mean, as off the cuff and out of the box as we are, there still is a certain modicum of standard of care that we were trained in
Yeah.
and that we take seriously. I mean, I'd like to point out that it looks sometimes, I think people think that we just sort of throw like conventional medicine out the window, and we do often just so we can treat our patients
Right.
appropriately. But the truth is that we still are very much part of the allopathic world, and we still respect it very much.
Yes.
And have a lot of great, understanding of the value it has. And so standard of care is still
Right.
important. And
Right.
when you have to monitor safety labs because you've put them on a drug that can affect their kidney, can affect their liver, and so on, or cause hyponatremia or cause low white blood cell count, we are responsible for looking at that. So
I think
it's an important point.
It's such an important point. Another aspect of it, another way to say it is, yes, you and I are every day doing out of the
Crazy
box,
stuff.
repurposed, crazy sounding stuff. Okay,
Right.
but there are standards, and what I'm
It's
trying to
not
say
the
is
Wild
that
West.
if we have the tools and the ability to generate usable data, even if it's so-called mainstream data, I'm going to do that first.
Right. Absolutely.
So as an example, I'm sure I'm going to create some anger here. There are a few things that get me crazier than when a patient comes in and says, well, I took antibiotics for 2 years. Okay, could you show me the tests? Well, nothing came back positive, but the doctor touched me and waves his hand over me and said, oh, you must have Lyme disease.
That exists?
Absolutely exists. And I got to be careful how I respond because I don't want to make the patient feel terrible. But that's like crazy. All right? We have the tests. The tests are not always accurate. They're difficult. But I don't care how out of the box you and I are going to be. If we don't make use of what's available
I
and
agree.
accepted, and we just say, I think this and I'm so smart, it doesn't matter, that is just the road to disaster as far as I'm concerned.
I agree. And I've never heard that really exists because there's so many great tests to use.
It really exists.
Okay.
Or it came back negative, but I'm sure you have it. You know? And I understand where that comes from.
Right. So
but-
I'll only ever say something like that along the lines of like massa, and we've talked about how
Yeah, well,
difficult
that's a
those
different-
labs
to
are.
me, that's
are
different.
hard. Right. But clinically, you can tell when it's a massa.
Well, and also there's a big difference between giving Zyrtec
Zer-
and Pepsid and giving ceftriaxone and daptomycin.
Right.
I mean, come on.
That is so true.
So,
Do you want to, I mean, I know we went really long, but do you want to just sort of cover like antiparasitics and stuff like that? Other than what you've already mentioned for babesiosis?
I think we should do a separate one on that.
Okay.
Maybe that, and we didn't really get into pandas-like illness,
Right.
which is a different category of infection in a sense to me, but we probably should address that at some point as well.
Yeah. I mean, do you want to do it now and just make this one long?
I think I need a break.
Okay. We'll give your voice a break. All right. Well, I want to say goodbye. Say goodbye.
All right. I hope I didn't confuse everybody. You know, I do want to end by saying, you know, there really is no absolute right answer on this. And I would caution that if you